It's a pleasure to introduce our distinguished speaker, Dr. Ben Anderson. Dr. Anderson is a professor of surgery and global health medicine at the University of Washington. As a surgical director of the University of Washington Breast Health Clinic, Dr. Anderson cared for patients with breast health issues and diseases from 1994 to 2020. He served as president of the American Society of Breast Disease from 2005 to 2007 and vice chair of the National Comprehensive Cancer Network Breast Panel from 2013 to 2020. Dr. Anderson has worked internationally in global cancer control for over 2 decades, with joint appointments at the Fred Hutchinson Cancer Research Center, Division of Public Health Sciences, and the University of Washington Department of Global Health. Dr. Anderson chaired the Breast Health Global Initiative, a wonderful initiative that really impacted my career, and I loved learning from it, which pioneered, and that's me, by the way, speaking, which pioneered the development of resource-stratified guidelines in low and middle-income countries. Dr. Anderson served also on the board of directors of the UICC, Union for the International Cancer Control, from 2012 to 2018. He received the 2011 Partners in Progress Award from the American Society of Clinical Oncology, the ASCO. The 2013 Inspiration Award from the National Consortium of Breast Centers, and the 2019 Pioneers of Global Health Award from the Washington Global Health Alliance. Now, in 2020, Dr. Anderson joined the World Health Organization and now serves as the WHO Medical Officer leading the Global Breast Cancer Initiative, launched in March 2021. Today, Dr. Anderson is going to talk to us about this, and basically, welcome, Ben. It's wonderful to have you, and thank you for supporting our work, and I'm so excited to hear your talk. Welcome.
Well, thank you very much, Dr. Shaheen. I'm honored to be here. I'm so amazed at the fabulous work in progress that you've been making. And so I will share my slides here that, as Rola said, I'm going to be talking about the Global Breast Cancer Initiative. And our thesis is that this is a bridge for global cancer control. My prior work before coming to WHO was as the chair and director of the Breast Health Global Initiative that was at the Fred Hutchinson Cancer Research Center, with support from Susan G. Komen in that initiation. Let's leap right into this. So what in the Global Breast Cancer Initiative, we're going to talk about 4 different areas. First, what is the overall need? Let's talk about early detection and what does that mean in a limited resource environment. We'll talk about the initiative itself and the approach that we're taking from this global perspective. So first, the need. Breast cancer is the most common cancer globally, and that takes men and women together. It is the most common incident and prevalent cancer among women and is the leading cause of cancer-related deaths among women. There actually are more disability-adjusted life years lost by women to breast cancer than any other malignancy. There's this common misconception that breast cancer is really just a problem in high-income countries. Actually, the majority of cases and deaths occur in low and middle-income countries today. And the problem is getting worse. By 2040, 60% of the projected 3 million new cases and 70% of the 1 million new deaths per year will be in low and middle income countries. And there's this huge range of how we do. The 5-year survival for breast cancer in high income countries is greater than 90%, but it's 66% in India and 40% in South Africa. And so there's a clear disparity that occurs here. But I would also turn that around and suggest this is an opportunity because it shows that we do know what it is that can be done. The question is, how do we do this in settings where there are limited resources? In sub-Saharan Africa, when we look at this population where people are young, half of the breast cancer deaths occur in women under the age of 50. And for every 100 of those deaths, there are 210 children that become maternal orphans. So this is not only a cancer problem, a health problem, a social problem. This is a generational problem, and that's why we need to be addressing this today. We need to talk about early detection. And that is because there is this misconception that we have to do everything the same in limited resource environments that we do in high-income countries today. In the early detection, we have excellent evidence that mammographic screening saves lives, that when we do mammographic screening, that we will reduce breast cancer mortality by 20 to 23%. However, the idea then that we just go create screening mammography programs is actually not the initial step or initial strategy. When we look at the evidence for mammographic screening, our colleagues at IARC have looked at the evidence. This was a very broad perspective, and it is clear that we have sufficient evidence for the use of mammography for the women ages 50 to 74. However, if we say, what about women under the age of 50, the evidence is actually quite limited. And we have no evidence about women under the age of 40. And this is a big problem. If you think about screening mammography, this doesn't tell you about what to do in women under the age of 45. We do have limited evidence that this can be cost effective, but the point here is it's not where we begin. WHO talks about the distinction between screening, where we look at overall populations of asymptomatic patients, versus early diagnosis, where we are looking for individuals who have early symptoms of cancer. And you have to begin with this place. So that means the difference between looking among a very large group of women, if we screen 1,000 women with mammography, we will need 200 that will need some diagnostic workup to find perhaps 7 cancers, 1,000 down to 7. Whereas if we talk about symptomatic patients, those presenting with lumps or early symptoms, then now we're talking about a 10-to-1 ratio. That is much more practical and certainly as important as an initial step. The question is waiting until symptoms develop, is that too late? Do we have to find them when they're at this very early point? Well, we now actually have evidence about the use of clinical detection. Randomized trials have been done in India, 2 major trials. And what just last year published, what it showed was that when women undergo clinical examination every 3 years, that we actually do, in fact, downstage disease. We see reduction in this advanced stage disease, which is such a problem in low and middle income countries. We see that 47% present with advanced stage in India without clinical detection versus 37%. And they did, in fact, see mortality benefit in those that underwent clinical detection. But that mortality benefit was in women 50 and above. Please note, mammographic screening actually is very similar. So the point here, this is not a criticism of mammography. It's not a reason not to use mammography, but the point is you have to begin with clinical detection, especially in settings where advanced stage disease is a very common problem. I want to point out this very important study that Dr. Shaheen led, which was an understanding and analysis of attitudes about screening among Muslim women. This has been one of the major driving studies that we look at in our work in the Breast Health Global Initiative. And because we tend to assume that when we do something in a public setting, when we do it in the general public, that they will do what it is that we thought they would do because that's what we would do. And in this survey of women living in Gaza and women outside of Gaza, 90% said they would be willing to undergo a mammogram if they had a complaint. And 86% thought that it made sense that early detection was beneficial. However, in these same women, when they were asked, would you have a screening mammogram if you had no symptoms, now you're down to 27 to 50%. And this is true not just in Gaza, this is true throughout the world. Many countries, the Philippines as an example, where women, you said there's something in my breast, oh, come in and have a mammogram and I want to do this diagnostic workup. That is not necessarily true. So my point here is one must have an understanding or at least guidance from people that understand the culture and the belief system if we're going to be effective in what we do. So now let's talk about the overall Global Breast Cancer Initiative. Our objective is to reduce global breast cancer mortality by 2.5% per year. And if you do the math, What that would achieve is saving 2.5 million lives globally between 2020 and 2040. There are 3 pillars to this initiative. The first pillar is health promotion for early detection. The second pillar is timely breast diagnostics. And the third pillar is comprehensive breast cancer management. I'm going to get into the specifics of these in a moment. But conceptually, what we're doing is marrying 2 belief systems, 2 scientific approaches. One is the public health sciences side, where we think from a group perspective. What do we do in a group overall? But we're marrying this with a clinical perspective. The clinical perspective being, what do we actually do in patients step by step? Because if we look at the improvements that have actually taken place in high-income countries, it was through clinical management. It was the interventions that were done. And so now the question is, how do I do it in a limited resource environment? These are the survival curves in a group of high-income countries and one upper middle-income country. And what you see is this very common feature that initially there was an increase in breast cancer mortality in the 80s. Then beginning in approximately 1990, there was this plummeting, reduction in breast cancer mortality. And that drop that we saw was overall a 40% reduction in breast cancer mortality. That's part of those statistics that we were talking about early on. If you ask, what is the slope of those curves? Those reductions were between 2 and 4% per year that was actually achieved. So when we talk in GBCI about a 2.5% reduction in global mortality, this is not an artificial or fictitious number. This is a real number. It was actually done with tools that we would consider standard today. The question then for us in GBCI is, how do you translate this to middle income country environments that have not yet seen these benefits? What do we do? What are the steps that we take? And the thesis is that we consider this from the patient management perspective. So these are those 3 pillars. The first pillar is the initial presentation interval when the patient enters the system. They might enter based upon a mammographic screening program. That certainly is one of the possibilities. But again, remember, that's the older women. The majority of women present with breast symptoms, whether it be a lump or a thickening, or in some settings, ulceration of the skin, advanced stage disease. That is the clinical entry point. And keep in mind, even when we do mammographic screening, at least half of the patients are still presenting clinically. So it's not optional being able to work up a breast lump or breast abnormality. That is an essential initial component before screening can even be contemplated. The second interval is this diagnostic interval. We see the patient, we do imaging, we do tissue sampling, we get a pathology report, and that distinguishes who is benign findings for who has cancer. And what is often not understood in the public health sciences realm is actually that cancer diagnosis is a fairly small group. In the palpable lumps, it's a 1 in 10. In mammographic screening, we're starting to look at numbers that approach 7 out of 100. And so we have to have that in place. And then that third pillar, treatment. How do we manage the patients with strategies that are well known and understood? That first pillar, health promotion for early detection. This is an educational initiative. The public needs to understand what it is that needs to be done and why they would participate. So understand, why would I come in? What do you mean that I might have something that's not really bothering me, but is actually a problem? Educating the women is essential. And we want to link this to other activities. So educating women about what the early symptoms are and linking it to, for example, cervical cancer screening. That's an opportunity to provide education, linking our approaches. But we also have to educate the providers, because if the primary and secondary care providers do not recognize early stage disease, that will create delays. And so educating the primary providers is essential. And doing clinical breast assessment training so that they know how to work up lumps in the district level facility, this is a key and important issue. Our goal here is to be able to achieve 60% of invasive cancers being stage 1 or 2 at diagnosis. Why 60%? Why is that a threshold? This is because of a study that we published last October that looked at global experience with who's been able to reduce breast cancer mortality and who has not. We had 35 countries out of 141 where we had adequate data about staging and survival. And what we found was there were 20 countries that had that sustained reduction, 15 did not. What was the common finding? At least 60% had in stage 1 or 2 cancers as at diagnosis. And so that's a threshold. There is no country that we have found that didn't have at least 60% stage 1 or 2 that have reduced breast cancer mortality. This is important for ministries to understand so that they can set thresholds of where do I need to focus. Our second pillar is timely cancer diagnostics. And being able to do a diagnostic workup, these are standard tools. When we talk about ultrasound, pathology services, they just are often not available. And so making them available is essential. Sometimes we may want to use leapfrog technology. So doing PCR to identify tumor markers and identify who is ER positive versus negative. These may be new strategies. And we have to not forget the patient navigation. How do we get the patient through that pathway and being organized in ways to do this? We should be able to make a diagnosis within 2 months, within 60 days. Why is that? Because when we look at survival, when we get to 3 months, that's when you start to see breast cancer mortality worsening. And so it gives us a time frame for making diagnoses. Unfortunately, that's not often achieved in limited resource settings. For treatment, this is what we know so well. Multidisciplinary care with surgery, radiation, drug treatment, having organized systems and patient pathway navigations that we get the patients through. Systematic assessment. We have to be able to measure our outcomes. If we don't measure our outcomes, we won't know if we've made improvements. And we do not forget about the patient afterwards. We have to remember they return to their community. Financial toxicity is a huge obstacle, and they need to have follow-up care. The target that we have picked for GBCI is for at least 80% of patients to make their way through treatment without abandonment, meaning that they make it all the way from the beginning to the end. It's not the first dose of chemotherapy that matters, it's the last dose. And it turns out that it's very common for patients not to complete therapy. In that study that we just talked about, of this 141 countries, we found that there were 2 factors associated with successful breast cancer mortality reduction. One of them was degree of universal health coverage. That is, are we paying for this? Out-of-pocket payment virtually guarantees that we will not succeed in reducing breast cancer mortality. And the other is access. The number of public cancer centers per 10,000 cancer patients correlate with this outcome. It's access and it's funding. Finally, the approach. What is the approach that we take with GBCI? We go through this series of assess, plan, implement, and monitor, because each country and each region within countries is going to have different needs. So by assessing, planning, implementing, and then figuring out, did it work? This is a cyclic process. It's not a single intervention. It's making stepwise interventions work. Here in sub-Saharan Africa, we now have real-world data from the ABC-DO study run by IARC. And what you see here is the red bars are how much improvement they would have in survival with improved treatment, how much they would have if they could downstage disease, those are the green bars, and how much if we can improve access and reduce social inequalities. So this idea that you just can't get there in Africa is not true. And the 3 pillars that we talked about can achieve these outcomes. In the ABC-DO study, the orange bars are those patients who started treatment within 3 months and actually got all the way through. It's half of the patients. So being able to complete treatment is not optional, it's essential. And therefore, if you just start treatment, that's the worst of all worlds. You get the side effects without the benefit. We are looking at models of how to implement these strategies, and we have to go in steps, establishing the program and then establishing screening and early diagnosis through whether it be through clinical exam or mammography or going sequentially, and demonstrating to ministries of health what it is that what benefits that they can see. And equally important, what is it going to cost? Because to a ministry, they need to know how much to invest. they're not picking between breast cancer and not breast cancer. They're picking between breast cancer and other competing demands. And they have to address all of that. We from the clinical community need to understand this. So in summary, we now have mandates from the United Nations to be addressing breast cancer and non-communicable diseases. Breast cancer is an index malignancy. If we can improve breast cancer outcomes, there are a lot of diseases that we can improve on. Early diagnosis is an initial step. And whether one is doing mammographic screening or not, you have to begin by being able to work up the clinical or palpable disease before thinking about clinically occult disease. To be effective, early detection only works when it's followed by treatment. So we can't just do early detection or just do treatment. It's the linkage of those two. We believe that GBCI could be a catalyst for change by developing approaches that are relevant to women's cancers and women's health throughout the life continuum. I'd like to acknowledge the superb support and help that we have through WHO and our colleagues that are making this all possible. Thank you very much for your attention today.